So welcome to GAP, MASLD and MASH, the community network. I'm Anna Hefner, and you cannot see me online right now. I'm in San Diego at this point in time, and we had a power outage and an internet outage, and so I'm trying to get it all back up working, and hopefully it'll come on at some point. And we have Dr. Renee Pozza with us as well, that is also here. And we are both from Southern California GI and Liver Centers. Both of us have the honor of being fellows in the ASALD. Both of us have our PhDs as well. So for this meeting to register, if you have not already registered, please take the QR code and complete that. And we'll start MASLD basics.
So thanks for joining us, everyone. It's great to have this opportunity as we're getting to talk about our favorite subject, which we used to call NAFLD or NASH. And so today's presentation will be really kind of giving us an update of where we are with state of the science and the new nomenclature, which has been out now for about a few years. But just briefly, when we look at the idea of what we used to call NAFLD or NASH or fatty liver, really looking at the umbrella overarching new nomenclature is the steatotic liver disease or SLD. And so just this slide, I think, depicts for you really what we're talking around is metabolic dysfunction associated steatotic liver disease, or MASLD. And so there are some patients then that will have this metabolic associated hepatitis or MASH. So we're really focused on today, how can you in your practice differentiate between MASLD, what is MASLD, and then what is MASH, because that's the what we're really trying to prevent is the fibrosis that comes along associated with MASH. So we'll, over the next few minutes, walk you through some slides to talk about that. There's a new category under this new nomenclature that's called MET-ALD, metabolic-associated alcohol liver disease. And so you can see in the center of this slide, it's really, is it predominantly the fat in the liver that's associated with just steatotic liver disease, or we also know that alcohol can cause steatosis in the liver, and so is it more of a predominantly issue with the alcohol related? So as individuals have increased alcohol intake, then we could have this overlap, and so you really, part of your assessment then is looking at their weekly alcohol intake, both male and female, and how much they're drinking. Then the other to the right of the screen then is the alcohol related liver disease. And then certainly those individuals that may have some overlap or may have underlying liver causes for damage in the liver, like Wilson's disease or hepatitis C. And then there's some individuals that'll have cryptogenic, which basically means you have fat in the liver, steatosis, unknown origin. So Anna, I'll turn it over to you for the next slide.
Okay. So they've changed the MASLD definition just a tiny bit, and it just really makes it inclusive. We've been dealing with NASH, or non-alcoholic liver disease. The histological changes of steatohepatitis remains unchanged, so the NASH part of it doesn't change. But what we've added to it is the metabolic component, and part of that is because they seem to be all working together. We used to call it metabolic syndrome with NASH. Now we call it MASLD, so it's very inclusive. So we start out with steatotic liver disease, and we have to really identify where we got it from. Is it from an imaging, like an ultrasound, a FibroScan, and we'll go back into those in a little bit, or a biopsy? Did we take a biopsy, have a core biopsy, and it says that we have fatty liver? And does the patient have any metabolic component? So yes or no. Usually the yes part could be because of overlap with alcoholism, as Renee just said. It also can be related to diabetes, cardiovascular disease, hypertension included, and hypercholesterolemia included as well. So we have to look and see what other causes could be and what else do we need to treat, because we treat it a little bit different by who's in charge of it. And then if there's no causes of steatosis, what else can be there? Okay, is there a monogenic disease? Is it Hep C? We know Hep C sometimes has fatty liver associated with it. We know that different drugs that we take, for whatever reason we need to take drugs related usually to rheumatology, will overlap with it. Wilson's disease overlaps with it. And so there's other things that can cause it. So we need to determine if that's part of it, because we treat, again, that a little bit different. Or do we have absolutely, positively no idea what we got here? And then that's called cryptogenic, because we just can't figure it out. The criteria right now for MASLD is, for adults, is that you have to have one of 5. You can have all 5 of them, but you have to have at least one. And it is the BMI greater than 25. So now you're overweight. If you're of Asian culture, it's 23. They tend to have a little bit lower BMI than Americans. We can look at waist circumference for males and females, and then you have to adjust that for the ethnicity of the patient as well. If you have fasting serum glucose, diabetes, either pre-diabetes or diabetes, that puts you into this category, and it's usually a type 2. Type 1 doesn't actually qualify for the MASLD. They can have it. They can have fatty liver disease, but it's a different origin from that. We also look at blood pressure. We look at hypertensive drugs that they're on. We are going to look at plasma triglycerides and HDL cholesterol for them. So they need to have one or more of them. And for pediatrics, again, it's 1 out of 5. They have the same exact as adults for this, except that you have to kind of remember you're using a pediatric scale. You're looking at BMI by pediatrics, not by the adult BMI. So remember that when you're looking at it, because they are different. And again, we're looking at cholesterols, triglycerides, we're looking at blood pressures, and again, diabetes, because we are seeing it much younger in kids right now. Okay? Renee, you want to move on?
Sure. So on this slide, how will this change your practice? So I think really probably it will affect not too much in how we manage patients. It's just the terminology that we're using. So there was a consensus statement that with experts in the area that really looked at this, and some of the drivers for this is some of the stigma associated with the term non-alcoholic fatty liver disease, even the idea of fatty liver disease. And it will be even challenging for Anna and I to get away from using that term fatty liver disease. So really it's the terminology that we're learning around MASLD and MASH. The studies all suggested that the overlap was definitely there between the two populations. All of the recommendations, both in the European guidelines as well as the American guidelines, can be applied to patients with MASLD and MASH. And so really all of the results from a lot of data around natural history and biomarker validation studies really show that the old terms are really applicable to the patients as we're using under these new criteria.
One of the things I want to make a comment about, and Renee had said it in the last slide, is that there really was a stigma associated with NASH. Non-alcoholic, you don't drink? Really? Those are the questions you would get from people. And also obesity was well tied with NASH. It's still tied with MASLD. However, it now includes other metabolic reasons. Again, as we said earlier, it has BMI of greater than 25. Okay, you're overweight. You're not obese, you're just overweight. You have to look at waist circumference, and you have to think about how to measure waist circumference. Pick a spot and stick with the same spot, because everybody measures waist different. They measure it at the waistline, but if you have a big belly, they measure it with using the umbilical or the belly button. And again, people's belly buttons are high and low. So you need to think about where you're measuring it from. In our practice, we tend to use the iliac crest. Everybody has their hip bones, and so we measure it from the iliac crest so that we're consistent. If you have cirrhosis and you have ascites, that changes where it goes. Where do you measure on ascites? Fasting glucose is greater than 100 or hemoglobin greater than 5.7, and you're going to go, wait a minute, that's pre-diabetes. You're absolutely right, it is, but you are working your way towards diabetes, or if you have already diagnosed type 2 diabetes. Blood pressure is greater than 130/80 or treatment for hypertension. Because if you're on drugs, hopefully it's less than 130/80. Triglycerides greater than 150 or on lipid-lowering agents. We have to remember triglycerides at 150 is what the standard is. Remember, if you're diabetic, it can be a little bit higher based on having type 2 diabetes and being treated. And then you look at HDL less than 40 or again, on a lipid-lowering agent. We also need to know that it excludes patients with alcohol consumption greater than 20 to 30 grams per day in men and in women. Okay, this is MASLD with cardiac metabolic risk factors. And it's sometimes easier to say, oh yes, I have a heart problem. I have a cardiac problem. It's a little bit more accepted than I have fatty liver disease. So we have to think about how we present it to your patient. It's all about presentation to your patient and how you're going to get them to work with you and make themselves better.
All right, so in summary then, I think really what you're looking for in those individuals is what are those cardiac metabolic related risk factors, as well as then the source of the steatosis in the liver. And so in primary care, how do you screen out these patients? And so that really the guidelines recommend a screening tool by using something called a FIB-4. A FIB-4 is calculated by patient's age, their platelet count, their AST, and their ALT. And so those are the 4 primary things that are put into a formula. And then you have a score that's associated with that. A score that is 1.3 or lower is someone that's very low risk for having fibrosis. And you can see in this chart, somebody who has a score or a FIB-4 of greater than 2.67 is somebody that's at risk for fibrosis and needs further evaluation. So then your determination is how much fibrosis is being seen in the liver. So we know inflammation then leads to fibrosis. More and more advanced fibrosis then is what we call cirrhosis. And so you're really trying to stratify and identify those patients that have fibrosis levels of what we would call a stage 2 or greater, because those are the individuals, especially in a setting of a type 2 diabetic, that are going to be at higher risk for development of liver-related complications. So this is an easy way. Those of you that have an EPIC, you can ask your EPIC then to calculate the FIB-4 score for you. You certainly could order it through a lab test, but it can be done as a point of care, especially if your electronic health records have a way for you to calculate that because of the 4 factors I mentioned. Anna, I'll let you talk, since Anna is such an expert at FibroScan. How do you use the FibroScan in the identification of these patients?
Well, there's a couple of things you have to remember when you use FibroScan. The FibroScan needs to be done by somebody experienced or trained and certified into doing FibroScans. If you're not, you can be all over the map with your scores and you don't get good readings. And someone else will have to do it again at a later time. But it's really a measurement. Patients don't eat for 4 hours before they lay on a table. You use the FibroScan machine, which is a pulsating machine. We use that and it captures fat content as a CAP, a CAP, or it covers K pascals, which is more the stiffness of the liver. And based on those numbers, there's a formula that you can get. It's not really a formula, it's a scoring pad, and you just get it and you just check off where your patient is, and it will tell you what the fibrosis is of the patient based on their diagnosis. So that helps you a lot. So for fatty liver disease or metabolic disease, we look for anything less than 7 being a 0 to 1, which is perfect. That's what you want to be. The average American is between 5 and 6, but up to 7 is perfectly normal. When you get up about 13 or 14, now we're starting to look at cirrhosis. And so we have to remember now they've got a lot more scarring that's going on. So we have to look at it from that particular, and we're going to have to do more things for them. We use, besides the FibroScan, we do look at their labs. We want to see what they look like. We want to see what's going on. What is their liver enzymes? Are they elevated or are they normal? What is their alkaline phosphatase? We want to look at their platelets. Again, gives us a clue about what may happen with cirrhosis. And we want to look at their BMI. And so we're looking at a number of things associated with it. And we now have a new blood test called an ELF, Enhanced Liver Fibrosis, in which we send it off and it calculates out a number that says we're at high risk, medium risk, or high or low risk. Again, putting all of it together gives us a better picture of our metabolic associated dysfunction patient, liver disease. So now we go into, okay, so now we figured out that they've got something. They've got a FibroScan of 7.6. Okay, so it means they've got more than just normal fibrosis that they should have. So now we want to start looking at what other things are they doing. So we're going to look at a liver biopsy if we want to. If we're not really sure what's going on, we are going to take and we're going to look at other blood works. We're going to look at that ELF. We're going to look at those numbers and see what's going on. We could do imaging. Again, we talked about that in the last slide. And then we determine whether you're stage 0, 1. That's good. I don't have to see you for 2 to 3 years. Well, I don't have to reassess you. Let me qualify that. I do need to see you because we have protocol that we need to give them, like we need you to lose weight. I need you to lose 10% of your weight. I need you to exercise. And that doesn't work very well when you tell a patient, I want you to go home and lose 10 pounds. And here's a 1,500 calorie diet or an 1,800 calorie diet. And they look at that and they go, oh, okay. And they don't like half the foods that are on it. Well, you lost them there. You tell them to exercise. I don't have time to exercise. Well, do you think you might have time to exercise around the block once or twice a week? Can you walk for 5 minutes and then increase it to 10 minutes? Give them chunks of stuff to do. Don't say, I need you to exercise 150 minutes per day or a week. They're not going to do it. So if you give them little, you say 5 minutes would be perfect. When you go to the grocery store, park way in the back and then walk forward. Is it a lot of walking? No, in most grocery stores, but it's walking, it's moving, and they will start to feel a little bit better. If we are in stage 2 to 3, we decide that's where you're at. We have to reassess you annually, and you have to consider pharmacotherapy. That's those Wegovys, semaglutides, Zepbound, all of the GPL1s and 2s. But it's also a new drug that just came out, which is called Rezdiffra or Rezidome. It also works for them to decrease the fiber. So the weight loss drugs will help them lose weight. And then we have something that will help break up the fat to get them better. So we have to think about that as well. And then there's stage 4, which is cirrhosis. Okay, if we expect cirrhosis, if we have an ELF greater than 11.3, we now have to treat them as a MASLD patient or a MASH patient, but we also have to treat them as a cirrhotic patient and all of the innuendos that go with that, such as we need an ultrasound every 6 months. We need to look at alpha fetoprotein. These patients are higher risk for liver cancer. They're not waiting until they have cirrhosis either. So we are seeing it very early in the stage 4. So we need to monitor them as well. So those patients need to be treated by the hepatologist, gastroenterologist. The stage 1s and 2s and 3s can be treated by the primary care very easily. You can call your hepatologist that you work with and ask them a couple of questions. You are welcome to do that. In our practice, we get calls all the time related to that, but most of it can be done with you in primary care.
So I think in summary, it's identifying those patients that are at higher risk, and we've reviewed that using your non-invasive therapy testing to identify the patients, looking at it, do I have inflammation and is it leading to fibrosis? And if so, how much fibrosis? So now this gives us a little bit of a picture of global epidemiology. So what is really the prevalence of MASH and MASLD? We can see about 30% of people in the US will have MASLD, and with a higher incidence in South America and Latin America is up to 44%. And you can see the rates here in Asia and Western Europe, East Asia, South Asia, Australia. So definitely, you are going to pick up these patients, whether you're identifying them in primary care, whether you're working in a gastroenterology practice and they're coming in maybe for some routine screening and doing that with you, and you might be able to identify them there. Or certainly we're going to see more advanced cases in the hepatology practice. So now let's review some of the natural history. And so we know for MASLD, we're dealing with about 60 to 80 million Americans, with a subset of them that are going to have more advanced fibrosis, which we call MASH. Over time, then, we feel like the progression rate in fibrosis is about one stage every 7 years. And so this is where we're really going to want to try and do what Anna was just talking about, lifestyle modifications, identifying these patients early, seeing what we can do to keep them from progressing any further. There are a subset of patients that will be fast progressor and will move quickly through these stages into cirrhosis within 10 years. And so as we identify those individuals with fibrosis, Anna did mention it, what we're really trying to identify early is the people that will go on to liver cancer or hepatocellular carcinoma. Oftentimes you see this when the individuals are already in the stage at 4 or cirrhosis. However, we are picking up individuals with MASH at earlier stages of fibrosis with a hepatocellular carcinoma. And so you'll want to screen those patients that you feel at risk with ultrasound, alpha-fetoprotein, or some sort of imaging. And then the rest of the slide here shows over the next few years, then you have people that have cirrhosis. This is quickly becoming the #1 reason for liver transplant in the United States, and certainly wanting to prevent liver complications, transplant, and obviously liver death. Turn it to you, Anna.
Again, it's a review because I think, we get really nervous about what's happening. We have 60 million people that have been the MASLD, and then we know that we're going to have patients progressing into cirrhosis at some point in time. But there's new stuff coming out as well. We know that obesity, we know that diabetes, we know that metabolic syndrome, we know cardiovascular and alcohol use will make it go faster. And so we really need to work with our patients so that they're not abusing what they shouldn't be abusing. We need to stay in a relatively stable weight. We need to slowly lose weight. Losing weight real fast actually makes it worse because as soon as you get to your goal weight, then you start eating again. And then you gain it back. It's that yo-yoing that can cause more problems. We're now identifying genetic markers so that we can look at it. We look at it in families. This is probably done more in the tertiary centers than in actual practice at the local level. And we also know that there's a big, huge gut microbiome bile acid alteration that goes on as well. So we know that disrupting your GI tract has become much more in the focus of what we're doing. We are doing more EGDs to see what's down there. We are treating the diarrhea and the constipation as well, just again, a little bit more because we're realizing that it does affect MASLD and the progression of it. And again, you get it, you go from F1 to F3, F3 being advanced fibrosis, going into cirrhosis, and then you have hepatocellular carcinoma. So we have a number of things that we have to look for. The AASLD has provided us a number of guidelines. So MASLD with F2 to F4 fibrosis puts you at higher risk. We know that we're at higher risk for MASH. So those are the ones that we're going to treat more often, see more often. We're not going to leave them out there for 2 years. Only the MASH F1 is going to stay out there for 2 years, then without a lot of intervention with us. The rates of fibrosis are progressing. Hepatic decompensations depends upon your baseline. Genetics, individual environment, and comorbid. It's really important to say, what's your family like? How many of your people have diabetes? What did your family members die from? And you're going to find out a lot of them died from fibrosis, or not fibrosis. They'll die from some liver disease that they don't know what it is, but they had diabetes that they had a hard time controlling. They'll find that they died of cardiovascular disease, which is the most common reason MASLD patients die. So we have to look at those. And if we know that other family members have it, this puts this person again at a different risk, a little bit higher. We know that cardiovascular disease, especially those without advanced fibrosis, is it, and it predominates with advanced fibrosis. We don't see F01s dying from fatty liver. We see the F3s and 4s dying from fatty liver, and mostly it's from the complications associated with it.
So now we're going to go and talk about just a case presentation. So how do we put this into our practice and in the real world? So this is a gentleman who comes in, 55-year-old. He's been referred to you because his liver numbers are elevated. He's got some right upper quadrant discomfort. He's gained about 20 pounds over the past 5 years. You look back at his labs, previously he's mostly had some normal liver chemistries with some mild elevation. He's got a past medical history of obesity. His BMI is over 35. He's pre-diabetic and he does have hypertension. He has no known family history of liver disease. He has rare alcohol consumption. He works in IT and is treated for his hypertension with some lisinopril. Upon exam, you find that his waist circumference is 110, indicating central adiposity. So Anna, how would you evaluate Mr. JP?
Okay, so Mr. JP has to have some labs drawn, and some of these labs are already done by you as the primary. And if you're in primary, you still need to do them, and then you send him to hepatology if he's really in bad shape. So we need to look at that. We want to see, does he have hepatitis? There's a number of people that have hepatitis that we don't even know have had it. They didn't know that they had it. The CDC recommends that all adults have a viral load or viral panel done. So we need to get his done for A, B, and C. Make sure there's nothing there. We do want to look at his ferritin level. We want to make sure he has enough iron and the saturation, the transferrin, and the TIBC, the ferritin, and those kinds of things. We want to do an AMA because we're looking for autoimmune disorders, because autoimmune hepatitis can also play a factor in this. And I'm going to skip celiac for just a second and go to AMA and ASMA. Again, those are for autoimmune. We're giving him a workup that says that we don't know why you have it, or this is why you may have it. Then we do a celiac panel because lots of people say they have stomach aches and they don't know why, and they may end up having celiac disease where they need no gluten. But even the celiac panel it's a good panel to do to know. But there's two things you need to know about it. One, they can't change their diet before they have the test. Because if they change their diet and get rid of most of the gluten, it'll come back negative when they may have it. And then they go back to eating and it comes back. You have to redo it as positive. And the other thing that you need to realize with the celiac disease, it may come back negative and you may be sensitive to the gluten. So if my patients come back negative and they still complain of abdominal pain with it or diarrhea with it, I tell them, you know what, let's try to avoid some of these foods and see how you feel. Then we're going to do some more blood work. We'll do the CBC, the CMP, the INR, see about clotting times. We're going to do for the HIV. We're going to do lipids, hemoglobin A1C, thyroids, and a PEth. The PEth is used for alcohol, just so that you know that. I have patients who say, no, I don't really drink. And well, okay, so I drink occasionally. What's occasional? Occasional can be once a week, once a month, could be just at Christmas and New Year's. It could be, I only drink in the morning every day. I don't drink all day. I only drink in the morning. That's a very different definition of occasional. So I have my patients spell that out a little bit if I'm looking at alcohol as part of their issue. We do abdominal ultrasounds. There you can see on there, there's a liver, there's a kidney. Again, as you look through it, as you look at the one on the bottom, it's got the one on the top, you see all the blood vessels in the kidney or the liver, and on the bottom, you're just seeing kind of thicker tissue, and it's probably echogenicity that they're marking. Echogenicity has been translated into fat when you read the reports. Doesn't quantify the fat. That's why the FibroScan becomes important, so we can quantify it. But we also can use an MRE. You can do an MRI, MRE, and they will calculate out the percentage as well. if we're worried about it. Anything over 4% on a MRE is going to tell us we have problems. Okay, I guess I'll just do the ultrasound since I kind of did it. Again, you're just looking for echogenicity. You want to make sure it appears smooth, not nodular. Nodular tells us we have cirrhosis. We want to see if the spleen is enlarged. Remember, the liver's on the right side, the spleen's on the left side, and remember that they communicate back and forth, and they put pressure on each other. So the pressure of the liver goes there, the spleen has to enlarge. If the spleen enlarges, it's trying to push pressure back to the liver, but it can also push pressure into the esophagus and cause esophageal varices. And then there's no portal hypertension on the one previously. So we're in pretty good shape for that patient. Okay.
Well, I think this is an important slide when you, because you may still wonder, the gold standard really is to look at the histology in the liver and looking for the isolated steatosis, and you can see in the bottom, it shows more of a picture of MASH. You definitely see the ballooning. That's a key fat indication of fat in the liver, is the amount of ballooning that you see. However, in practicality, many of us are using these non-invasive testing to determine fibrosis and the amount of fat in the liver. So it's an important question of when do you then recommend biopsy for your patient, knowing that it really is the gold standard. So I think it's when you have indeterminate non-invasive markers. In other words, you might get one score on a FibroScan, which is not equivalent with what you see in your FIB4 or your ELF. If you've got somebody that maybe is older age and you're considering that, sometimes you might consider it on the other side too. The FIB4 is definitely better for individuals that are between 35 and 65. That the younger patients and the older patients is probably the accuracy is not as great for them. And so, or if you're just trying to say, do I have another underlying cause of liver disease in that patient? So, it's a carefully selected group of patients that you're going to biopsy, but there still may be indications for when you would biopsy a patient. All right, back to our patient, Anna.
Okay, before we get back to our patient, I want to talk one other slide, or their slide. Another issue is medications. Find out what your patient is on. Are they on methotrexate for psoriasis? Are they on tamoxifen for breast cancer? Are they on corticosteroids? Are they on antiretrovirals? What are they on? That makes a difference, because some of those medications will put or create some fat in your liver. We talked about a lot of the diseases, other etiologies. We think about starvation and malnutrition as, oh, they're going to lose a lot of weight, but that can cause a lot of problems in the metabolic system. So you really need to think about it. And if they're on parental nutrition, patients are on all kinds of stuff that they do at home now. So we really need to know what they are. But back to our patient, the steatotic liver disease. Well, we know that he has a little bit. Does he exhibit any other metabolic? Yes, he does. He has metabolic dysfunction, MASLD. Does he have anything that is going to be overlapped? Yes, he does, because remember, we know his blood pressure is elevated. We know that he has prediabetes. We know that he has some triglycerides. We definitely know about his BMI. So he's got more than one criteria that fits the MASLD definition. Okay, we don't have to do pediatrics because he's not pediatrics at this point in time. Okay, so if we go to the next slide, talking about our patient, we want to just, or I guess it's the other one that goes on top of it. We really want to know, does he have underlying steatohepatitis? Does he have MASH? The answer is yes. Does he have any fibrosis? I don't remember what his exact number was, but I believe he does. But he did not have advanced fibrosis or F3, F4. Okay. Any questions about how we described him, or what we made for him, or how we had him come through? I kind of would like to end with the fact that we are seeing more obesity. We are seeing more type 2 diabetes, so that the prevalence of the metabolic dysfunction associated steatosis liver disease, or MASLD, is really increasing and rising. And that we need to remember that, lifestyle interventions, healthy diets, increased physical activity is really the cornerstone that we have for managing these patients at this particular time. And primary care, when you're going to do that, and we definitely appreciate it, or if you're in hepatology and GI and you're doing it from that perspective as well, is really work with the patient. Really find out what they want, because if they want it, it gets done. If they're just listening to what we rattle off about what to do, they don't necessarily follow up, because this is a disease you don't see. Like, well, nobody, okay, so I'm overweight. I've always been overweight. My family's been overweight. Why should I worry about it? So we do need to make sure we work with those patients. Okay, any other questions?
Here's a QR code so you can complete a short survey, share your thoughts. There's also more information. Should certainly utilize the resources that GAP has as we educate both GI and hepatology APPs, but also reach out to our primary care partners. So thank you for attending today, and we look forward to your feedback, and best luck with your screening and treatment of these individuals to make a difference in the care for the patients and families we serve.
Thank you.